Hi, good morning. My name is Ed Jauch. I'm the chair on the leadership committee for the American Stroke Association.
And I'm Joe Broderick, President-elect of the Stroke Council for the American Stroke Association.
We're here to discuss the Ims Iii trial that Joe presented at this meeting, not only to get into the details as to the trial itself, but actually how it may relate to your clinical practice. So Joe, for those who are not here today in beautiful Hawaii, can you tell us a little bit about what the trial found?
The Ims Iii trial was designed to test an approach, was using IV TPA to start, like we would do in every stroke patient who's eligible for IV TPA, but then take those patients to an angiogram where we use a catheter to go to the site of the clot and use additional medication or to use a thrombectomy device to remove the clot. And we were comparing that with the standard treatment, IV TPA, within 3 hours of onset. Now, when we started the trial, we wanted to make sure that we didn't have an obsolete trial in a couple years. So we allowed for new technology as it became approved by the Food and Drug Administration and other government authorities to be allowed to be included in the trial as long as we thought it deserved to be included as an investigative team, and the NIH also agreed with that. So we tried to keep pace with the developing technology. So we're testing approach versus IV TPA. And what we try to do is to take the advantages of IV TPA, which you could start very quickly at any hospital that has a CT scanner and a knowledgeable physician, with the advantages of intra-arterial or endovascular approaches, which can open up the artery better and hopefully result in a better outcome. And we hoped that we'd be able to see about a 10% absolute difference between the combination treatment and the IV treatment. Unfortunately, what we found is that while the safety between the two approaches was almost identical, very similar, we really couldn't see that signal of a benefit overall for the combined approach as compared to the IV TPA, which was disappointing. But we learned some things from Ims Iii when you start looking at the data in more detail. So for example, when you look at the patients who had the more severe strokes, those who have an NI stroke scale score of 20 or more, there was a signal there. Actually, there was a 7% difference in the favor of the combined approach. Now, that wasn't statistically significant, but that's a signal that maybe the big strokes may be more likely to respond to the endovascular or combination approach. As compared to the less severe strokes, those who had an 8 to 19 stroke scale, where really the difference was really negligible between the two treatment approaches. In addition, what we found is that if you looked at those patients who had a baseline CT angiogram before they got any treatment, those that had a blockage in the terminal part of the internal carotid artery and who got IV TPA, they did very poorly, and a relatively small number of them even opened up at all. So only about 5% of those people actually had a Rankin of 0.2, that would mean functionally independent, as compared to the combined group, which is about 25%. So that's a big difference. Still, a lot of those people don't do very well, but again, a pretty clear signal there that that combination approach may be more useful in people who have the biggest clots in the largest arteries. However, when we went to the middle cerebral artery, we found really no difference between the combination approach and the IV TPA. The other thing that we found when we look at subgroups in the study is that those subjects who were treated most quickly with IV TPA within 2 hours, or who had their groin time within 90 minutes of the start of the IV TPA, that those subjects tended to do better with the combined approach. Again, not statistically significant, but indicating that probably time to delivery of the endovascular procedure is extremely important, just like it is for delivery of IV TPA and standard therapy. So, well, I think to summarize, we think that the combined approach is safe. The combined approach overall was not really much different than the IV TPA, but when you start drilling down into subgroups, you say that people that are treated early and people who have really big clots in the biggest arteries, in the internal carotid artery, probably are good candidates for endovascular therapy. But again, these are things we're going to be doing more studies and research about, but I think Ims Iii gives us some clear ideas of where we're going in the future.
That's a great summary, Joe. And I think if you look at Ims Iii in the context, it's 3 because there was Ims II, Ims I, and even a prior trial of EMS. One of the things that you alluded to is we've seen time incrementally creep up. And so this gets back to not so much the trial design, but stroke systems of care. that if we do this approach, whatever we do has to be done very quickly for both the IVTPA, but also the mechanical embolectomy. So it's not just the devices itself, but the stroke systems of care that involves all levels of hospitals that feed the system to manage these more complicated, more severe strokes have to really focus on time.
I think in the future, we're now seeing this strong push of the golden time window for IVTPA, and we're pushing that at all the centers across the country. We're going to have to push as hard or even harder for the endovascular time to treatment as well, both in terms of the systems of care, as Ed was referring to, from the outside of the hospital, but within the hospital. We just can't dally thinking we got it all the time in the world, because when we spend that time, we may open up the artery. In fact, we open up the artery in a lot of the patients in Ims Iii, but we didn't change the outcome. And so that's the thing that we have to work on.
Yeah, we've seen devices actually become faster. So some of the newer devices actually can reopen the artery faster, but that additional incremental benefit over previous devices is lost if you delay transport or delay in-house access to the cath lab. So regardless of your level of a stroke position, whether you're a non-stroke center, telemedicine, primary, comprehensive, each of those has to look at themselves and say, what can we do to streamline the treatment of these patients and integrate hospital A and hospital B and per hospital C if they have to go to each one, and eliminate as many of those time barriers as possible.
And brought up some of the newer devices, and that's actually one of the limitations of Ims Iii, is that while we were including new technology, the new technology was going along pretty fast, and so we got stopped before we could have many of the new stent retriever devices included in the trial. However, while that technology we think adds something added to the technology we had before, if we don't deliver it in soon enough time, it's still not going to have the impact that people would hope.
So clearly from this trial, we have our marching orders as a stroke community, and we've known that time is brain since the early 90s. And so now we have even stronger evidence that we have to work together to preserve this time is brain theory. Where do we go from here? Besides just the system development, what's your next step?
Well, I think there's a combination of treatments that we can look at. There's only so many patients who have acute strokes that qualify for trials. So one of the things we have to be creative about is how we can combine maybe a couple of different approaches together to provide the most benefit for patients, and then maybe have the endovascular available for those subjects who are not clear about where its best use is. And so that's one possible way, but it also means we have to maybe think about how many studies we have ongoing. If we have so many studies, none of them get done in time to answer the question. So I think we have to, as a community, say, okay, what are the things we got to get done, and let's get them done.
All right, I can't agree more. And I think that if you look at how Ims Iii evolved, we had to reach out to additional sites, additional countries, additional continents to be able to recruit effectively to get patients in these trials. And if it's going to take us 10 years to complete a trial, science outpaces that recruitment. And so we really, like you said before, as a stroke community, need to work collectively to prioritize what we think are the most likely therapies that will benefit our patients, effectively and efficiently test those theories, get some data on that, and then move forward based on our findings. So
this is the International Stroke Conference. Really, we're talking about international stroke trials as being the future, and that provides, we had the experience at Ims Iii. It's not easy because every government has its own set of rules, and how do you move studies out into other government structures? How do you deal with, how do informed consent differently in different countries? How do you deal with drug and things like that, medications? So there's challenges, but they're challenges that are doable. This is a global society, and we got to find ways to do global trials.
Well, I can just speak personally. It's been a very educational and at times humbling experience working on the trial, but I can't think of a better group of people to have done it with. And so not only do you get the benefit of promoting science, you get the benefit of participating with friends and colleagues, and that's part of the fun of being in stroke research.
Absolutely.
Great. Thank you, Joe.
Thank you, Ed.